Hi everybody, I'm Gabrielle Nicholson. I'm the Senior Portfolio Manager for the Perioperative Harm Program at the Commission. I thought I would start the presentation by just giving you a quick refresher on where we get our information from, because I am in my subsequent slides going to talk about the current state. So we get information from the serious adverse event reports that come through to us. We talk to our colleagues at ACC about treatment injury related information. The Health and Disability Commissioner, we have a good relationship with them. Of course, we interrogate the National Minimum Data Set, and we also look to OECD data to do comparisons and look at where we are in comparison to our compatriots overseas. So I'm hopeful that most of you have seen this before. I like putting it up because it's a really good summary. It makes for very sobering reading though. I think in particular this one here, foreign bodies left in during the procedure, look at our rate compared to the OECD average, and then this one here, the punctural laceration, same, not very positive comparison there. I've also dug out some of the perioperative SAE information over recent years, and again you can see it's the same information but just shown in a different way. Look at these ones here, the retained items and swabs. This one here, wrong site, again, and more other useful information about the current state. This one is the one that I really like to pause on because this is just a summary. I had many more that I could have put up, but I only wanted one slide. I might let you just have a wee look at that. Apologies for the summary statements not being as useful as they could be. This is the information that we get provided with, and so in some cases this is the only information we get if they don't go on to do a full Part B. One thing I'm really pleased to see is this one here, near miss, no harm. We really encourage that type of thing to still be reported because first of all we can celebrate that the mistake was caught before there was any harm, and secondly a mistake was still made, so we can still learn from it. So what can we do to stop this type of thing happening? We've talked a lot today about improving the culture, improving teamwork and communication. We have talked about some specific interventions that have been designed to address these types of issues: briefing, all three parts of the WHO Surgical Safety Checklist, and debriefing. We've also talked a lot about how those interventions should be used to engage the team, to improve teamwork and communication. Report the events and learn from them. The serious adverse event reporting process is just getting better and better as people realise that it's a crucial part of learning from one another and also internally. As I said before, celebrate the near misses. And this last one, Clifford mentioned this, and I really want to emphasise it. We really want to tell stories. As part of the program rollout, one thing that I would absolutely love to happen, I'm going to work really hard to make sure that it does, is we get some case studies from you guys around what you tried, what worked, what didn't work. When you had a success, what did you pin it down to, so that DHB X down the road can learn from you. There's only so much that people are willing to hear from the Commission, and they would take it much better if they're hearing it from their peers and colleagues. So I'd really like to get some case studies up on our website, get familiar with the things that you're doing. So if I hear of another similar situation, I can straight away make the connection, and also get you guys up on stage presenting at these types of events. There's lots of evidence about the benefits of using the checklist. The one at the top I'll just quickly draw your attention to because it is pretty hot off the press, and it was mentioned earlier. The first ever randomised controlled trial of the checklist in Norway, which found a decrease in complication rates of about 42% and a reduction in the length of stay. I'm not going to go too much into the detail of this because I'm aware of the time. Again, lots of evidence around how effective briefing and debriefing is. These slides will all be available on website, so you can take your time and read them properly. So we have had fantastic achievement in recent years on getting the checklist used, but I think that, and I know that we have driven the wrong type of checklist behaviour. We've created an audit approach where people are more concerned about tick, 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 tick sign, and the hard copy piece of paper goes into the patient notes. So I hope you've all heard this. We're retiring the QSM that relates to this one because we recognise that we got it wrong. So, hopefully inside you're all doing a happy dance. You don't have to submit that information anymore. So in 2012 we did a survey about attitudes to the checklist, and I know 2012 was a few years ago now, but I think it's still worth putting it up there. It showed that there was a lack of understanding about the overall intent and applicability. I think most crucially it shows that it wasn't seen as a tool to support patient safety, teamwork and communication, and that's what we're really wanting to change over the coming year, get people to have that shift in mindset. The proof of concept project was all about testing ways to address this. So just in case you're not familiar, last year we did a lot of work with Waikato and Lakes District Health Board and Southern Cross here in Auckland, and we've got some representatives from the teams that took part of that here today, so we owe them a debt of gratitude for putting in some really hard yards and doing some great work for us, and we have learnt a lot from it. So what the key factors are is about giving you guys enough lead-in time, supporting you to engage, and giving you all the support that you need to prepare before we go to implementation phase. Also, crucially, clinical leadership, having the leadership at that senior level. So not only do you have your project team, but you have your Director of Surgical Services or whatever their equivalent is brought in, and ideally you have your Chief Executive or your CMO or your CNO aware of what's going on and prepared to be champions to support you to make the change. We also learnt that the tools do work as intended, and the tools I'm referring to are the ones that Miranda put up really briefly: ISBAR, 2-challenge rule, closed loop feedback and call-outs. Teaching people those methods, while it's a little bit clunky to start with, as people get used to them and get to use them more freely, they really do make sure that the checklists and briefing and debriefing work appropriately. And it wasn't the point of the exercise at all, but happily we're able to report that there were efficiency benefits. So, apologies for the busy slide. What are the plans? So I've already mentioned no QSM, so that's pretty good. We're doing a phased rollout. We've already gone out and communicated with all the district health boards and asked you guys to identify which cohorts you want to take part in. We did encourage people to go in with their regional buddies, because that's going to make things easier when we go to do the cohort-wide learning sessions, less travel, because the cohort 1 learning session will be in Auckland, the cohort 2 will be in Wellington, and the cohort 3 will be in Christchurch. But some DHBs have taken that on board and then still decided to go in a different cohort, which is absolutely fine. Each DHB will receive targeted training in how to implement the changes during your cohort's preparation phase. So that means trainers coming to you at a time that works for you, when you can get your team to take time away from theatre to learn about the interventions and the communication tools and practice them in a safe environment before we go to implementation. We are going to have a new QSM. We've got a 1-year hiatus. I had to negotiate to get that with the Ministry of Health and the Minister, because they are the people that are really interested in the quality and safety marker data. So over the course of the year, while we're doing implementation, we will be training you in how to collect data for the new quality and safety marker, which will be exactly as Mike described. Observational audits, measuring levels of teamwork and communication, we're using a 7-point scale. So really crucial part of that is making sure that all the observers have the same understanding of what constitutes 7 out of 7 and what constitutes 0 out of 7, so we don't get observer bias creeping in. So we'll be doing a train the trainer model. We've stolen the idea from the hand hygiene program, with the idea being that we'll train representatives at each DHB who can then go and train their peers, so it's not all coming down to just one person. We still have to work through the detail of exactly how many moments will need to be observed, but it won't have to be sign in, time out and sign out for the same operation. You can have an observer come in, probably observe the sign in and time out for the same operation, because they're usually close together, go away again, come back in. It could be a completely different operation. They're there in time to observe a sign out. The other thing I should mention is, as part of the proof of concept, we developed an app which can be used either on a desktop computer, it can be used on any handheld device, where the data can be entered straight away, then and there. So the auditor's standing there, he enters it, it's submitted. You don't have to go away and enter it in later. And you will be able to look at your own data in real time. We will want to do an extract 4 times a year to do our quarterly public reporting. You guys will be able to look at it as and when you want to, and it will give you information about how you're tracking and how you compare. Your data you'll be able to see, the rest of the data will be anonymised, so you'll be able to compare against other DHBs. You won't know who's who. But there will be training in that. And then in the 2016-17 year, we will have the new QSM, and this is a pictorial representation, so you can see Cohort 1 July, coming up really fast. That's the preparation period. They'll have a learning session where all of the members of the cohort come together. They'll then have the intervention training prior to moving into implementation phase. So it's at that point that, however they've decided to roll it out, the posters will go up on the theatre walls. So it might be they've decided to do it in a particular suite of theatres, so that will go up, or it might be across a particular service. It's up to the DHB to decide that, and that's where we've planned for the auditor training to happen. And you can see down here, this is when the data gets submitted for the public reports. We have treated January and December as dead months, which is why for Cohort 2 and Cohort 3 you do see extended preparation periods. The other thing I should mention is that we are wanting private hospitals to take part in this and come on this journey. So we're working with the Private Surgical Hospitals Association to get contact details for all the private hospitals so we can get them in communications. I hope you're hearing comms from them already. And we're also working with the Southern Cross leadership as well. What we want to happen is that the neighbouring private hospitals that you work with, because you send your patients there, or your surgeons also and your anaesthetists also work there, get invited to take part in the learning sessions so they learn with you, because that's just going to be the easiest and best way to do it. We can't force that to happen, obviously. We can't force private hospitals to take part. We can't force you to invite them to your cohort learning session, but that's what we would like to see happen. The other thing I'll mention is, and you might have heard from them already, we are doing a culture survey as kind of establishing our baseline. You know, the litmus one that I showed you before from 2012, a few years old now. So we're doing another one, and I know people are getting a little bit surveyed out. You'll have to forgive us on that front. We want to understand what the baseline is so that we can measure and see change. So we've contracted a professional company to do that, Mobius. They'll be in touch with you to get that happening across your DHB. You've seen these already. The version I've got here is actually the penultimate draft. I got so much feedback over the last 2 days about how horrible this colour was that we've changed it, so it's now an equally horrible green. But these are examples. You guys can use whatever version you want to use as long as it meets a kind of gold standard around what's included and what's excluded. Feel free to take our ones, change the colours, put your own branding on it, or we're going to put up on the website the Auckland ones. Southern Cross have done a lot of work on their checklist. We'll put that one up. We've got permission to do that. And just today I've bailed Mike up and said, can we please have the version that you flashed up on your presentation to put up as an example as well. So equally, you might not want to design your own, but you might not like ours. You might want to use White Matters. Over to you. And there's the debriefing one. So, options for support. One thing we learned from the proof of concept is that it is hard work, and you do have to sustain the energy and the effort. So, in addition to the learning sessions, we're also going to do webinars that'll be voluntary. You can dial in, talk to your colleagues online. And the training that I've already talked about, you can choose any one or all of these options to get some support. Ian or Miranda are happy to come and talk. You can get them to come to a grand round, or you can get them to come and speak to a particular team or a particular person, even if that's what you need to do. We've got quality improvement advisors in at the Commission who can help you with your data. You know, when you're looking at the data on the app and you're like, what do I do with this? Give us a call, we can help. We've got lots of resources on the website. For the people who need all the information about the evidence, we've got an evidence summary that's really good. What I'd love to see happening is if you want to get connected with another DHB and work together on something, that would be fantastic. Or you hear that a DHB's done really well and you want to know how, we'll connect you. And then the other point is give me a call or send me an email and I'll see what I can do to help. That's it, but has anybody got any questions? Yep. Fantastic. Well, we'll link into that. That'd be really good. So that was theatre managers have set up a LinkedIn group, so that's great. So I had a couple of questions in the other regions that I think are worth sharing here. Somebody asked, now that we're moving to a paperless approach, what about the audit requirements that are there that mean that you have to be able to demonstrate after the fact that you did a checklist, you completed the checklist? Now, I'm not aware of any audit requirements. There's no national standard that says that you have to have done that. If a DHB has put that in as part of their quality standards, I'm sure that a one-liner in a patient note that says the checklist was completed, yes, no, and you can tick it, I'm sure that would suffice, but that's actually something you'd have to resolve internally. I'm not aware of anything that requires you to have evidence, a piece of paper, and certainly that's not come from the Ministry of Health or the Commission if there is. So that was the answer to that question. There was another really pertinent question. If you've read between the lines, you will have picked up on the fact that the new QSM that is coming out for 16-17 that we've got you reporting on via the app is about levels of teamwork and communication with the checklist. We're not going to be measuring the levels of teamwork and engagement with briefing and debriefing for a whole nother year, because we recognise that those bits are the entirely new bits and could be harder to embed, so we've given you more time on that. One other point. Somebody said, what are we supposed to do between now and our cohort starting? That's entirely up to you. You can choose to do nothing and wait for us to come and knock on your door and wait to receive the how-to guide and all the information, or even better, why not start now and get a head start? But that's up to you. Okay. No questions? Cool. Thank you.